it was mind-blowing to me then, and it is just as much now. And I think maybe every time I see a patient's eyes like look at the screen and they're like, that's what's going on? Oh, I did not know that could be the thing. I'm like, yeah, this is
right.
And it's life-changing for people to realize that too. I feel like that's why I love this job, because it's like Christmas when people are like, what? This is actually what's going on?
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you two.
Hi there.
All right, on the show this week, we're going to be talking about the people side of metabolic medicine because, as you know, medicine is a people industry. Without people, it's hard to get good medical help. But one of the reasons that I think this show is going to be important, Dr. Cooper, is that the connection that we have with you as a provider has been really, I think, one of the most important things about our medical journey. And when we get bombarded with questions from people all over the world saying, hey, can you recommend a provider? We've got some advice later in the program about that too. But people connecting with people to create better metabolic health is really an important thing. So you have a special guest joining us, Dr. Cooper. Why don't you introduce her?
I do. I'm so excited and happy to have Alisha Boxley join us today. She is a wonderful nurse practitioner who braved the metabolic medicine world to join me at our practice in Seattle quite a while ago now. And so she has just become an amazing asset to our clinic and is just a joy to work with. So we invited her on to kind of show her perspective of what it's like in the field of metabolic medicine.
Wow, Dr. Cooper, that was really nice of you. Thank you for having me. It's like an honor to be here on this podcast because you are my biggest, I'm your biggest fan, of course, and so I'm happy that you chose me out of all the applicants. So I'm the lucky one, really.
Oh,
well, Alisha, it's great to have you here. I'd love to know a little bit of your backstory. How did you get into the medical world?
Yeah, so gosh, it's been over a decade now where I was like always in love with biology and the sciences going through school. And I just figured with the help of some friends that steered me into nursing, saying it's a great, like, humanistic job that you can, be involved in. I love people. I love talking to people. And it's kind of like I'm a Cancer, and so I just like that mama bear type of personality. And so I'm like, yeah, I feel like that could fit both worlds. And so I just started down the nursing path, which took me many years to get through a lot of school, but I was an ICU nurse for a very long time, like 14 years, and saw a lot of really deep stuff. And I just was like, one day I'm going to get into preventative care, and that's really one of the reasons why I thought Dr. Cooper's practice kind of called out to me as well, because in primary care nowadays, it's hard to get long appointments with your patients, and so I was like, I want to do something that's long lasting, that I can prevent heart disease and diabetes, because I see that so often in intensive care. And I was like, let me just go back to school and go through my master's program. And here I am at Dr. Cooper's Cooper Center for Metabolics, and I'm learning so much, and that's kind of how I got here. Yeah.
So what's interesting about your story, Alisha, is that you in the ICU would sort of see the end result, the catastrophic sort of end result of failures in human health, right?
Yeah, yeah. I mean, it's like I've seen the worst of the worst, and a lot of it starts with, probably, which I didn't know at the time. I wasn't making the connection as I call it a baby nurse, but like the metabolic side of what goes wrong after you let heart disease kind of get out of control and diabetes get out of control. I did a lot of post open heart surgeries in the intensive care, so I got to see like, yeah, people don't know what they don't know. And then I see the end result. And so I was like, how can I be a part of trying to prevent that? So why I went into primary care for sure.
That's such a good point, because I feel like I too in my career saw very sick people, and either was in the operating room dealing with these very sick people, or in intensive care in the hospitals, just real sick people. And it does make you think, geez, what could we do to prevent this? Is this preventable? And so much of it could be preventable. And so I totally can kind of see that same philosophy that Alicia's talking about, that it really hits you. And Alisha, you were probably inundated with a lot more than even I was as an ICU nurse. I mean, you see so much stuff in that situation, and you can just think, geez, what do we do to prevent things getting this far? And that's what I love about the preventive medicine lens. So when you look at metabolism affects so many different organ systems. So it's really the best viewpoint to take if you're trying to prevent those major diseases. And so I think that it just resonates for all of us at our clinic, that's exactly kind of what our mission is to try to reduce the incidence of preventable disease, preventable deaths.
Well, it's very interesting. I am at an age right now, uh, a specific age, old, where a lot of my friends and people who are my friends' friends are getting heart attacks, strokes. And to look at these people, you would not go, oh, well, of course that guy got a heart attack, or of course that person got a stroke. You wouldn't say that. They look healthy, they seem healthy, and sometimes they've gone to doctors often, and sometimes you find out, oh my God, they don't go to a doctor that often. And I think that we don't think about metabolic health as often as we really should, because I think when you keep up with your metabolic health, a lot of these stroke and heart attack markers are not overlooked. And like we pay attention to them because we pay attention to them because we have been. But I think that a lot of people don't. Do you find that, Alisha, when you're looking at patients and seeing new patients, especially now?
Yeah, I mean, I think one of the things that was most interesting about seeing a deeper level of the blood work that we do is, especially with cardiovascular disease, and speaking of like stroke and heart attack, is that when you get the cardio IQ and you get those genetic risk markers, it can tell a completely different story of what's on the surface. People are going to the primary care provider and it's like, oh yeah, the surface panel looks great, or oh, it might be a little bit elevated, let's just watch it. But then you're letting years go by without really knowing like how much damage is like further underneath. So that was really enlightening to me. I'm like, oh yeah, even now you see some patients were like, oh yeah, well, my doctor said before I came here that my cholesterol was fine or my lipids were fine, but then you see like the particles are like way high risk, and those sticky plaques are just like really like not under control. And that's scary to know that people are walking around that would never have any idea that they're in that much risk. So I think, I guess to answer your question,
Right.
It's interesting that primary care probably doesn't do it more than they should, or you know what I'm saying.
And it's amazing how the statistics show that even people who have had their medical appointments so many times, even things like diabetes are missed.
Right. Or they just say, oh, we'll just keep an eye on it. I have a lot of friends who either they don't know their A1C levels or they're like, well, it was a little elevated, but they said, we'll just keep an eye on it.
Yeah, until when?
Yeah. I'm like, until you
Right.
burst into the airplane, and you blow up and like blood
Well,
is gushing. Like, you need to look at that.
I think it's a mindset. The preventive mindset is like something that could happen to you in 5 years is an emergency today. That's
Yeah.
kind of the difference is we look at it as an urgent situation today. If we can see that your health trajectory is taking you in a direction where 5 years from now, something devastating could happen because the preventive window isn't forever. You've got to act now when you see something going in that direction. It doesn't mean you have to do, overly treat things, but you definitely want to help people be aware of their personal risks. Some people are aware of their family risks, and that's also good because they're concerned that they have these family risks, and that's one reason why they do want to look a little bit deeper than what they've had before because they just want more reassurance that they're not at risk for diabetes or heart disease or strokes in particular.
Yeah, when I first came to see you, Dr. Cooper, I was actually pre-diabetic, but my own family doc had never measured me for diabetes.
Right.
We were in that phase of let's keep an eye on the blood pressure, let's keep an eye on the cholesterol, let's keep an
all
eye on.
all the
I had everything.
Right. All the things. Like, let's keep an eye on it.
Let's keep an eye on it until Mark falls over. Then
And
we'll fix it.
that is a difference between like in the preventive world, you're not trying to manage diseases. You're trying to get them to regress and recede. You're trying to prevent them from getting worse, but not just manage something and be satisfied that it's, still stuck in this disease process that's progressive. And so it's a different mindset. And I think that's one thing that it has to be instilled, I think, from early on in your career or by experiences kind of like Alisha had where she saw what happens if you don't implement that type of a mindset. This is what happens. End stage disease that's just so devastating. But I benefited because my grandmother was very much into preventive medicine. She was a doctor, actually.
I was going to say, you better mention that she was a doctor, not just that she was into
Not just
preventive.
she was a pediatrician and one of the first women doctors graduating in 1914.
Wow, that's amazing.
From NYU med school. And she, from the time we were little, she always felt like you could cure anything by just washing your hands, eating your fruits and vegetables, and walking or doing, and getting enough sleep. It was just like the very basics. But, we've come to realize that's not always true. It's not that simple. But it did instill that preventive mindset, which is good because it makes people feel like they do have some control over their health because they can take these steps to whether it's getting a good workup or it's doing some different lifestyle strategies, they can make some difference.
Yeah. It's so sad to see some people that, if you leave things like high blood pressure untreated, it can literally ruin your kidneys and you can die from kidney failure.
Right.
And we see all kinds of extensions of that failure to keep track of what's going sideways. Alisha, I'd love to ask you more about you worked as a sleep medicine specialist. And sleep, of course, is such an important part. On our last episode, we talked about sleep being so fundamental. When people first come in, how common is it to see people with sleep problems who also have metabolic dysfunction?
Yeah, well, I mean, I had a short stint in that, but what I did find out is, especially when I would go to nursing care centers, that's where I treated most of my people and actually worked them up for sleep apnea, which is, a hugely underdiagnosed, I think. And so a lot of people that had metabolic type syndrome symptoms, like the company that I was working for before realized that, untreated sleep apnea was a huge portion of why metabolic dysfunction is going on. So when I would go, assess people for sleep apnea, you ask all the questions like, how are you sleeping and things like that. That was the biggest portion of things. It's a little bit harder, I guess, in the nursing skill facilities where you have lots of ins and outs all night, hard to get sleep when you have a neighbor and stuff like that. But I did find a lot of people that didn't have a diagnosis of sleep apnea that actually did have it. And once we got them worked up and started on the right testing and got them CPAPs or BiPAPs, whatever they needed, their sleep did improve quite a lot. And that's huge, obviously, for not only metabolics and decreasing cardiovascular disease and diabetes, but blood pressure, the whole gamut of things. And so being preventative in that way helps. And then, of course, just what Dr. Cooper's taught me is the sleep hours between, 11 and 5. If you can get that regularly, that's going to help with a lot of the other stress and all that bad stuff that can affect your metabolism.
I'm curious, when you went through your medical training, you're younger than the rest of us. So I have to
Not by
ask.
much, but
I have to ask, though, I have to ask, in medical training these days, how much of a focus is put on metabolic dysfunction or the metabolic system? Because we've talked many times on the podcast that there's a lag time between what we know about metabolism, what's being taught in medical schools. So what was your experience, Alisha?
I feel like when I was going through my master's program, it was, I guess I could say, very chopped. And so it's more of you're looking at different systems and getting through the education on, each system, but not necessarily like putting it all together and realizing that's all how it affects metabolism. So I would probably say lacking for sure. It wasn't until I started working here that I was like putting it more together, to be honest. Even as long as I'd been in medical care, it wasn't like priority to make sure that you knew that all these systems were like working together. It was just kind of like, okay, let's deal with the heart. Let's look at the kidneys. Let's look. And so it is separated when it should be more taught together.
Yeah, it's the same in, for doctors in med school. It's not presented as a systems kind of focus, or it's more the individual systems as if they're independent and they're not integrated and they're not interrelated, which isn't how the body works. And so I think that's one of the issues of why our metabolic system isn't really getting the attention that it should. But maybe with the new focus on the medications and seeing how many different organ systems they seem to be improving, I think people are puzzled. How can it be that the GLP-1s now are being shown to reduce cardiovascular risk? They're being shown to reduce the new term MASLD, which is metabolic dysfunction associated steatotic liver disease, which is a big long name for fatty liver. But they improve kidney health. They potentially reduce dementia. We don't know yet because the studies aren't finalized. But how could it be that one group of medicines is going to be able to make that much difference in the body? So maybe once people start seeing that, they'll understand that the body is not just separate systems, separate, isolated systems. It's one part of one big, huge, complex interconnectedness of different systems in the body. And the metabolic system is very complex, but it does influence every other system in the body. And that's why we should be looking at it more with that all-encompassing view instead of these little isolated tidbits. And I think doctors would come out of training with a much better perspective if we could change the training that way, doctors and nurse practitioners.
Yeah, I mean, if you think that a drug can be good for so many things, you must think how well that thing is interconnected with so many things in our body.
Right. It's obvious, right?
Yeah.
I was thinking too when you mentioned the GLP-1, it's our body's own hormone, or and then there's so much we don't really study hormones that much. Like when I was going through nursing school, that wasn't like a huge thing, but to know how all of that affects all the systems and brings them together, I don't remember spending a lot of time studying that stuff. So that could be an area of focus where it's like, okay, yeah, this hormone leads to this hormone, which leads to this, it's just
Right.
like, yeah, I didn't get that much. It wasn't a focus.
It's the neuroendocrine system, which, as I've said before, to me, it's like the glue that holds everything together with our health, and that all of our health aspects are dependent on the integrity of that neuroendocrine system and the health of it. But that's an area that's completely left out of medicine. And you don't have specialists even in medicine that are neuroendocrine specialists. It's so, but I think this should all just be in primary care. I don't think that we need to have so many specialists. I feel like our primary care field, if we could focus a lot more on our body as a whole, holistically, in primary care, and see things with this systems viewpoint, I think that we could make a lot more progress medically.
Well, I think that also is why, like, practices like yours spend a way longer time with patients to try and figure out all the connections.
Yeah, and these connections, right, Alisha, they take you down little rabbit holes
Yeah.
because then you find something and then that leads to another question, which then you have to try to explore that. And so a lot of our patients end up with pretty extensive workups that we find all kinds of things that you wouldn't think are related to the metabolic system. But because we're looking through that systems lens, we're seeing a lot of other aspects of health that are uncovered in our workups. And so it's not easy, right, Alicia?
No, it's not.
I always say that you guys are like detectives.
Yeah.
But it's a tough field, and everyone, not just the providers, but everyone's working really hard, like the medical assistants and the administrative people too, because long ago, and I think I told Alicia this when I first met her, but it was in my mind, I was always trying to figure out how do you create a preventive care model. And long ago, they did an analysis of why we don't have preventive care, and they came up with these main barriers. And what's interesting is this was like decades ago, but what's interesting is those are the same barriers we have today. And one of them is that doing preventive care puts a huge burden on a medical practice because you have to do so much more investigative work. You've got to track so many more things, and you've got to do a lot more patient interaction and involve the patient a lot more, and with health promotion or health education, or just simply having a conversation with them to find out more about their health and to can relay back to them what you're seeing. That's a huge part of preventive care. So that puts like a bigger strain on the administrative side of how you actually deliver the care. And then the other barriers were that the providers don't believe that preventive care can actually be very effective. And that's sad that providers would think that, but that stems from a lack of knowledge of preventive care and of what the benefits of preventive care could be, and a lack of experience in delivering the preventive care and seeing firsthand what a difference it makes. So that was another barrier. And the third one was a lack of information technology that can track everything. So those are the three key areas that our practice has tried to overcome and focus on. And it's not easy. I mean, I can see why they identified those as barriers, and I can see why we don't have the luxury of having a preventive care model in our society right now, because it would require a lot more tools and thought about how to deliver it in a streamlined way, because the administrative burden of it is really, really high. So it is that there's a big the providers are working really hard, but also the medical assistants, the other supportive administrative staff, they're also working really hard. And so I just wanted to put that out there. Just not that we feel sorry for ourselves, but just because I really appreciate Alisha hanging in there in spite of how hard it is compared to some of the other, pathways that you could have taken.
Yeah, I'm happy to be here. I'd rather be. I feel like I was born to spend like lots of time like talking to patients. Like I realize that for sure now because when I was going through like my interim training, I was like, I only have 10, 15 minutes with this patient. How am I supposed to like address all the concerns? And it's just tough. I feel really bad for the primary care in clinic, where you're having the mill of people where you have to keep up and it's tough.
Do you want to give an example of when you had to like dig deeper and found something that you normally wouldn't find in a quick appointment?
Well, let me think. I mean, in general, like when I was going through my training, I would say, you come in and you have a patient that has like 4 different things on their list that have been concerns. And then, maybe it's like chronic pain is a huge one where you're really trying to get to the bottom of like how can you address this person's pain. I know there's a lot of arthritis and things like that. I'm just thinking of a patient that I had in the past, but then they also have like sleep issues and things like that where I'm trying to get them the right treatment to treat their pain so then they can sleep better, and you just go down this road of like, well, I don't have enough time in 10 minutes to try to address both of these things. So now I'm, just like stuck, probably not addressing the most appropriate thing is like, this person needs sleep, and that affects metabolism, just coming back to everything. But I don't know. I guess it's hard for me to think way back and like out of that now. But I just think that there's not a lot of time where now I can take an hour to go through fine tooth comb everything and address much more. And then if I have to do a little bit of work outside or ask for backup with Dr. Cooper or something, I feel like it's easier to do that.
And you've found a lot of interesting things with our patients. I mean, some things that, when you do all this workup, there are some things that sort of don't make sense. So those are the ones that Alisha comes to me with because it's like, something's funny here. Like, where we can't explain why something looks the way it does. So then we both go on a process of trying to learn more about that situation and what could be going on. Because it benefits the patient if you can actually always answer that question, why? Why is this happening? And not be satisfied with, well, it is the way it is. I mean, if there's a way to understand more, that's going to benefit the patient.
Yeah, I agree.
And I think the reality, as you mentioned, Alisha, as medical clinics and companies are being bought and sold and getting larger and larger, that the accountants are really running the show now. And they're literally telling doctors, you have X number of minutes per patient today. And if they fall behind, they are reprimanded a lot of times. So I can understand why so many people are fleeing the medical industry. I'd love to know, though, Alisha, was there an aha moment when you transitioned to metabolic medicine? Like something that you understood for the first time or something that was just kind of blew you away?
I would say that once I realized that a lot of the weight issues, I mean, I feel like people come to us because it's like weight based. They're like trying to figure out why they've been fighting this their whole life or whatever. And then when you really start to see like the diets that people have been on have like just been burying that problem so deep, and then just like seeing patients with Dr. Cooper, I think it's like, okay, I get a taste of it. And then seeing my own patients, I'm like, oh yeah, it makes so much sense now that all of that diet damage that's come before has just been bearing insulin resistance underneath it. That's the like root of it. And I'm like, oh, there's so many people out there that are going through the same thing that have no idea that this is the problem. They're just being, like shamed or whatever. I even just had a patient today that's, battling with the outside forces of like why she's this is a little bit different, but I mean, I guess I was trying to explain to her like why that her insulin resistance wasn't there from the beginning, right? And so we backtracked on like when you first came in, your insulin was so suppressed because you were trying to do all the things that society's telling you to do, not, more dieting, not enough exercise. And then as we have progressed over this time, like, look what we found. Like, this is what it is. And I feel like every day I'm like that when I see a patient. I'm like, wow, like this is the answer to so many people's issue. For me, I would have never known that that was the case before I came to the Cooper Center. Just like it was mind blowing to me then, and it is just as much now. And I think maybe every time I see a patient's eyes, like, look at the screen and they're like, that's what's going on. Oh, I did not know that that could be the thing. I'm like, yeah, this is
Right.
and it's life changing for people to realize that too. I feel like that's why I love this job because it's like Christmas when people are like, "What? This is actually what's going on?"
Right.
Yeah.
That's so cool. And gosh, it's just so frustrating to see that calorie deficits are still being talked about as the answer, especially in social media, that all these people, they pull up their shirt, they've got the six-pack abs. When I started, doing a calorie deficit and blah, 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 it's like, oh my gosh, it's so frustrating to see that. But all that diet damage that you see firsthand is really at the root of this.
We see it in like every patient, right, Alisha?
Everyone.
Yeah.
I mean,
When
you
it's
see it
becoming to
all the
us.
time.
Yeah.
Yeah.
Well, Alisha, this has been super fun. Thank you so much for spending some time with us. We're going to let Alisha go, and then we're going to talk just about one final thing about connecting with experts when it comes to obesity medicine. So keep up the great work, Alisha.
Thank you
Fantastic.
so much.
Thank you.
Yeah, no, thanks for having me. I appreciate it.
Every time somebody says, "Oh, you've worked with Dr. Cooper, she's in Seattle. I can't go to Seattle. What can I do? Where can I see somebody? Who do you know? Who do I?" So, here's something you can do, Mark.
Actually, Dr. Cooper sent me this LinkedIn post from the American Board of Obesity Medicine, and I clicked on it, and holy cow, you can search out a provider who's an expert in obesity medicine. But first of all, Dr. Cooper, to get certified, and you were one of the first people probably certified in the state, if not the first, what does this certification actually mean in terms of training?
Well, unfortunately, it's not open to nurse practitioners or physician assistants yet, but it's open to medical providers. And so it's a board certification process. So you've got to take a board exam and you have to keep your certification going through continuing education. And I was just so excited. I was in the first group to be certified in 2012. That's when they first offered the testing. And so I'm really proud of that certification and maintaining that. But it's dedicated to people who have that passion in obesity medicine, which does overlap with some metabolic medicine as well. I mean, there's a lot of metabolic information in the board materials. There are now fellowships that doctors can go to that they can train in this before they take the exam. So it's a great field, and more doctors have become excited to be certified. And so now we're in a situation where I forgot how many they have that are certified now, but it's in the thousands or over 1,000, I'm sure.
Yeah, I just did a quick search between the U.S. and Canada, 9,700, almost 9,800 providers.
Wow. That's fantastic. And so, this is a great directory in terms of if in your area you're looking for someone, if you find someone who is certified in obesity medicine, and the abbreviation is ABOM certified, then they're more likely to be up to date with a lot of the different treatment options and a little bit more of the workup versus somebody who's not exposed to that training.
It's a good place to start.
It is a good place to start. You still have to see if they're aligned with your philosophy. I mean, you'll still find a lot of proponents of diets, even who are in the.
Right. But I think you could have a better conversation with them.
Yes, yeah, exactly.
Well, that's great. We'll put the link in the show notes so you can click on that and then search out a provider in your area. All right, this has been so much fun today. The people side of metabolic medicine. Thanks again to Alisha for joining us, and to you too for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.